All right. Welcome, everyone, and thank you for joining us today in one of the forums in our series for Reimagining Public Safety, a collaborative between the City of Ithaca and Tompkins County, New York. I'll quickly just go over the format for today's forum. We have Frank Kruppa, Tompkins County's Mental Health Commissioner, who will be giving a presentation on Tompkins County's mental health emergency and crisis services. And following Frank's presentation, we'll take some questions from folks who are on the Zoom, as well as if folks have any through the YouTube chat, and I'll moderate those to Frank to answer. We have about 45 minutes to maybe just a little bit more today, so I won't go on any longer, but I'll let Frank take it from here. Welcome, Frank. Thanks for joining us today.
Great. Thanks, Dominic. And thanks to everybody that's listening live and might be listening in the future on the recording. So I want to take some time today and talk a bit about the Tompkins County Mental Health Department services related to emergencies and crisis and how it relates to our intersection with the law enforcement and legal system. All right, the slide won't advance. There we go. So first up, talk a little bit about our department and what we do. So we have some very specific public safety related programs. Probably the biggest one of interest will be our mobile crisis team, and I'm going to talk a little bit more about that in future slides. So no, we'll come back to that. We do offer domestic violence and sexual offender treatment. We have staff that are specially trained to administer evidence-based programming to help individuals that are dealing with domestic violence or sexual offender issues. We also have walk-in crisis counseling. Walk-in looks a little bit different in a time of COVID, but our building is open and folks are able to walk in and talk to somebody in the immediacy if they are in a crisis. So we have an intake process and it begins with a very simple screening to try to identify those that might be in crisis quickly and move them into a more a more dedicated, specific crisis intervention rather than the normal intake process. We've also implemented Narcan training. So we are certified by the New York State Department of Health to provide Narcan to our clients. So for those folks that have a dual diagnosis of a substance use disorder as well as a mental health, we are able to give them Narcan as part of their visits with us. We do have a dual recovery coordinator. And so his role, some of you may know Rich Shaw, he's been in our community for many years. He helps both the department as well as our community partners that provide services to address dual diagnosis. I think we're all acutely aware now that many folks that have a mental health diagnosis also have a substance use concern as well. So he's been doing a lot of work to try to improve our processes around dual diagnosis. Assisted outpatient treatment, you may hear us call it AOT. It's Kendra's law, and it is essentially court-ordered outpatient treatment. And so we have a team of people that review potential individuals for AOT, and then if it's determined that we think that will be the best course of action for them, we work to get the court process underway to get the AOT order in place. It's important to know that you can't really make someone get treatment. What it is really an option that's provided to them, right? That the court is saying, if you're not compliant with this, there will be other consequences for you. And so it's really about trying to encourage folks that struggle with traditional treatment systems into a much more intensive process that is followed by both us as a department, but also the court system. And then probably our newest program, which we're really proud that we have here in Tompkins County now, is the Ithaca Wellness and Recovery Court. Its traditional nomenclature is mental health court, and it really is an opportunity for those that have a mental health diagnosis to take a different path through the legal system. We're really fortunate that we had community champions that really pushed to make this happen for us, and then we have some amazing judges. It really does require judges that are bought into there are better ways to treat people in the legal system that have a mental health diagnosis. So there's a team of folks that review those cases as well, and recommendations can be made, and then using the judge and the court determinations on folks' willingness and ability to participate are then decided from there. So we do have quite a bit of service that we provide related to public safety. And like I said, I'll talk a bit more about the mobile crisis team here in a second. Just quickly wanted to go over the other programs and services at the department. Personalized recovery oriented services, or PROS, is a program that we offer. It is a separately licensed program that is really designed for folks that need a bit more than just regular supportive therapy. It helps with skill building, coupled with their individual therapy to really help them achieve whatever goals they want. Generally, we're working towards being able to work, volunteer, or continue education, but it's really designed around the needs of the individual. So we're really happy to have that program. We do some medication assisted treatment for folks that are part of our clinic. Our main core services are around child and adult psychotherapy, both individuals and in group. We do school-based therapy. We're in many of the school districts in the community. We actually have staff that have a space in the school itself to provide therapy to students to try to take down, the barriers of having to come to our facility in order to get the treatment. We also do supportive counseling and injectable medications. So we have a cadre of nurses that works with our medical staff to ensure folks that need that level of care have access to it. We do child and adult medication management, and we also run the single point of entry and single point of access services, which really is an opportunity for individuals to be referred in and then connected with the many different services that are available to them in the community. You'll see on the right is a picture of our building. I'm sure folks are familiar with, and the nearly $1.5 million that the county commits to the department, and we have 65 FTEs that work with us. So let's talk about Mobile Crisis Team. I think this is a program that maybe a lot of folks aren't aware that we've had it for a few years now. It's kind of grown. Originally, we had a program called Emergency Outreach Services, which was just during the workday, so 8 to 5, where we would go out into the community if there was a crisis to try to support those individuals. A few years ago, we were able to develop a program that allowed us to expand that to 24-hour coverage. So that is now available. It's a crisis evaluation process that starts by phone, but can also result in us going out into the community. And again, it's a 24/7 operation. Services are available for all people that are at imminent risk of harming themselves or others. So that's important. This program is really designed for those situations where somebody feels like the individual could harm themselves or others. And we do work with local law enforcement agencies if they're involved as we continue to try to support the individual both through the immediate crisis and then on into the future. Our mobile crisis team can be activated by local law enforcement, but it can also be activated by really anyone. And we use our local suicide prevention and crisis line. They're awesome people that are manning phones and talking to people that need help in some of their most difficult moments. And we chose to partner with them because they already have a skill set of being able to talk to people in crisis, or family or friends or community members that might see or know of somebody that's in crisis, to help them, kind of navigate that process. So it starts with them. Their number is located here. And they do a phone triage, and they work through the process. If they're able to get the individual that is in perceived crisis into a safety plan that they're comfortable with, that they'll be okay until the morning, or until the next time services might be available, then that's the first step. That's really our first goal, is the least restrictive intervention to try to get people to a safe place. If they don't feel like that's possible, then they can activate the mobile crisis team. And so they will talk with the team that is on call and tell them about the situation. The team member might decide to talk to the individual or the person that's calling in to get more information, or to try to triage further as a licensed professional, with the same criteria. If they're able to achieve a safety plan where everyone's comfortable that the individual will be safe until the next time regular services are available, then great. That's the first step we want to have. But if they feel they need to go out into the field and meet with the individual, then that's what they'll do. And they will go out and they will work to try to get that individual to a safe place. So the mobile crisis team is made up of licensed mental health professionals. So we use the staff that we have at the department. We do have a forensics unit at the department that runs some of those programs that I referenced earlier on, but we really use everyone that's interested in being a part of the team at the department, from our community mental health nurses to our social workers that are part of the mobile crisis team. So these are licensed professionals. And again, they make the triage determination about whether they need to go out in person or if a safety plan can be established over the phone. In some instances, when they do evaluate the situation, it's determined that the individual really needs to go to the hospital for evaluation. And we use New York State Mental Hygiene Law 9.45. We tend to throw the lingo around about a 945, right? You may have heard that referenced, and it really is a reference to mental hygiene law 9.45. And that law allows delegated individuals to be able to require that an individual be transported to the hospital for evaluation. It's important to note, it doesn't require that they have to stay at the hospital. It really is a transport order for evaluation. And so once the individual is at the hospital, then the hospital takes over and they use the mental hygiene law that's available to them to do their evaluations and make determinations about inpatient necessity or other interventions. Again, if a hospital evaluation is not required, our goal is to get to a safety plan, right? And a safety plan really consists of, what are you going to do for the next 6 to 12 hours, or until your next availability with a clinician will be. What are you going to do to remain safe so that you're not going to harm yourself or others? And they really are trying to be solution focused and help the client get stabilized in those moments. We have a lot of follow-up partners that we can use. You can see some of it in the box to the right. We use our own internal resources, but also many community partners are available to us to try to support these individuals through their crisis. One of the questions I think we've gotten recently, well, we've been getting it for a long time, but I think it's certainly come to the forefront recently, is, can we respond without law enforcement? So if our mobile crisis team professional determines that it can be handled remotely without the need of a 945, meaning they're doing it over the phone and they're able to achieve a safety plan for the individual, then no, we don't need law enforcement for those instances. But we do have a policy that if our staff are going out into the field for a mobile crisis visit, that we expect to have law enforcement present with us. And the reason for that is we're going out for individuals that we believe are a threat to themselves or others. And while our staff are highly trained and capable folks, we have to be prepared to protect their safety in those instances. So that is the current process. We also work with the ambulance services for transport if need to be to the hospital. So it really is a team effort in these situations. I would also point out that there's many times where law enforcement, as I spoke of in the beginning, activates the mobile crisis team. So they may already be engaged and they've identified that there is a mental health issue that our folks might be able to help with, and they can activate us to be able to respond, or the mobile crisis team to be able to respond. We also participate in the crisis negotiation team. So this is a team of folks that is led by law enforcement that is designed to deal with incidents where we have perhaps hostage negotiations or barricaded individuals, or really other critical incidents where it feels like the skills of this team would be valuable. That is operated and activated by law enforcement only. And we do have mental health department folks that participate as a member of the crisis negotiation team. So I believe right now there are 2 folks that are credentialed to participate. One works for us at the mental health department. The other is the mental health worker at the Tompkins County Jail, someone that used to work for us and moved over into that new role when it was created at the jail. But both of them are highly skilled, highly trained, and they train with the law enforcement team that they are connected to. So when the CNT is called out, it is a team of individuals, and they are trained together, they exercise together, and they work as a team to try to get to the most peaceful outcome and hopefully have the best outcome for the individual that is in crisis. It is independent of the SWAT team, so it is a separate team, but it would be a rare instance where both the SWAT team and the CNT team would not be called out together. I just want to be clear, I'm not trying to create nuance here, just that they are 2 separate entities, but in most instances, they are both called out in these situations. As I said, it's activated by law enforcement only, and it is a 24/7 team as well. So shifting a little bit to kind of some broader perspective. You may know that in the end of 2019, the Tompkins County Legislature voted to merge public health and mental health together into a single department. And so we are in the process of doing that. We're a little delayed because of COVID, but we're still working on it, even with all of the extra things going on with COVID. And really, we understood that social determinants were a key part of health and safety in our community. And as we began this journey of merger, I've been serving as the department head now for over 5 years, I think it is now. And from the very beginning, it was clear as I had an opportunity to see the work of both departments that we were all very keyed into, we need to do work on social determinants of health in our community if we truly want us to be healthier and safer. So as we're moving forward, we're in the midst of a strategic planning process as part of that merger. And foundational to that is health equity and wanting to ensure that everyone in our community has equal access and ability to be as healthy and safe as they can be. And so that work is underway, both the merger as well as the strategic planning, which will help lead us into the future. And so we're excited to see where that goes. And I think, you know, being the public health director, it's hard to say anything good came out of COVID, but it put a little bit of a pause on the work that we were doing. And then as the anti-racism issue really got brought to the forefront, where it should have been a long time ago, it happened for us in a time frame where we weren't too far down the path and we could really shift And I think our strategic plan is going to demonstrate that we believe that health equity is foundational. And racism is absolutely a part of that. And we're committed to making sure that our programming is anti-racist, but also that we are thinking in everything that we do, how are we achieving health equity with this? Because we need to make sure that we are making that available for everyone equally. All right. I've talked a little bit about community partners, but it's really important. I'm talking about the mental health department today, but really we're just one piece of a giant puzzle in Tompkins County, and we're extremely fortunate to have many partners that do help people with mental health diagnoses or substance use disorder diagnoses. We have a structure. The legislature has the Community Services Board, which is their advisory board for the mental health department. And that board has 3 subcommittees that focus on substance use, developmental disabilities, and mental health. So there's an infrastructure. There are people that are very interested in these issues and have been working for many years. And I think there's an opportunity to coordinate and magnify the impact of some of those structures that already exist. And just a shameless plug, we are looking for people to serve on those subcommittees. So if you have an interest, please reach out to the legislature and submit an application. We have a lot of partners in the treatment community and the human service agencies. Some are probably watching now. Others that are watching may have interacted with these folks, but they're amazing people that have dedicated their professional lives to helping people be healthy and safe. And so we couldn't do any of this at all without all of them. And I think as we move forward and we talk about public safety reform, it's really going to take all of us to be at the table talking about what each of us can bring, and then how do we magnify that impact on our community. So thank you all for listening to that part of it, and I will go ahead and end the presentation and turn it back over to Dom for Q&A.
Great, thank you so much, Frank. We do have a fair number of questions that have been emailed in to me and submitted through our chat. So I'll begin with one that was emailed in from a community member this morning. They're wondering about how can folks get the quickest response from the mobile crisis team? They've heard or have had a few experiences with slower response times, and they're unsure what the fastest way to get a response from that team is.
Sure. So the way for the public to access the mobile crisis team is through our suicide prevention and crisis line. I can absolutely understand the concern that it might take a bit. Where these folks are on call. So one of the challenges with our mobile crisis team program is it's not its own entity. We are using people that are doing other work in an on-call setting. And so during the daytime, they're seeing other clients or doing other programming. And if a call comes in, they have to get pulled from that to go deal with the crisis. Or if it's after hours, they're at home, right? They're at home and they're on call, and the crisis line would call them and begin that process if they felt it was it was necessary through their triage processes. So it's not an instant access. We're not out patrolling. It is an on-call function. So I can certainly understand some concern about how long it might take for us to be physically present if that's what's necessary. But the quickest way to access the mobile crisis team is through the suicide prevention and crisis line. Got it.
Thank you. In your experience, has the mobile crisis team service had a good track record in Ithaca so far of lowering the amount of times police have used force or other things in certain situations?
Yeah, I think so. I think there's been multiple instances where our ability to intervene prevented something from escalating to where law enforcement needed to be directly involved. And I think, and I know this probably won't be a popular sentiment, but our local law enforcement, they've been a great partner in trying to develop systems where they can access mental health workers for folks that they come across where they really think that is the more appropriate way to address the issue. We obviously have work to do to improve things, but I think we have seen some success. And obviously there are times where it didn't work, right? And unfortunately, either law enforcement has to get involved or other more significant steps taken. And that is the nature of the work that we do. But our first goal, as I've said all along, we try to get folks to a safety plan that can get them to a place where we don't need additional intervention.
And in your experience, how have law enforcement officers been at recognizing mental health crises and calling them a mobile crisis team? Is that a quality service that they're providing? Are they integrated in well? Are they what's your experience been with those law enforcement officers?
Yeah, I think it's been good, not perfect, right, on their end or our end. Right, it's a relatively new program, only having been around for a few years. Making sure everyone's aware of what we do and how it can be accessed is an ongoing education effort that we work with local law enforcement, with their leadership, to make sure that the message is passed down about what it is we do and how they can access us. So I think it's been good. Is how I would describe it. I think we absolutely have room for improvement, but that goes for us as well, not just them.
Great. We've got a number of questions in about the anti-racist strategic planning that you're doing. And I'd like to encourage folks too. We're getting a lot of questions through chat. So if you'd like to ask in person, use the raised hand feature and you can ask that live so they don't all have to be sort of translated through me. But otherwise, I'm going to put a few of these questions together for you, Frank. So actually, you know what, we have a couple of folks who've raised their hand. I have Tali Mugambe. He's going to ask a question.
Hey, Tali.
Hey, how's it going, Frank?
Good.
That's good. So, I'm wondering, does the strategic planning process to address the social determinants of health and the root causes of the disparities that you guys have, this team, sounds like you have this team assembled, but does the team have non-governmental persons involved with the strategic plan that have been directly impacted by the current policies and protocols in place? And if so, are we available to know who those people and organizations are?
Sure. So the current planning process, the non-governmental, so the people that don't work for the departments that are involved, have been our board members, so our community service board and our public health board of health. They are participating in and helping play an advisory role. What I can tell you, Tali, is that we don't expect the plan to necessarily address the particulars of anti-racism. What we're trying to address is, we're trying to address health equity, but we need to have lived experience and community support to help us understand how to do that. So what you will see when the plan comes out is that one of our priorities is community. And that includes figuring out and getting lived experience in those that need our services, their voices to the table to help us design those services better. But probably more important is those folks that don't access our services or may never need to, but have experience with the system or with our system that could be valuable for us to include. So this first process is more of an organizational strategic plan as we try to move together, but you will see that one of our priorities very specifically is about what you just asked of us, is how do we get those voices to the table to help guide us in the future.
So just for clarity, the planning is not going to be laid out and then individuals show up to say, okay, this is good or this is, but they're going to actually have be sitting at the table and see how and discuss firsthand, right? Like how they can be valuable in the process and actually looking at what that looks, helping to develop what that looks like. Is that correct?
Yeah, yes, just to be clear, the plan itself is an internal document that we're working on for our future as a merged department. But the prioritization that we're putting is exactly what you described. We want people at the table helping guide our decision making about what we're going to do moving forward. And so, yes, it's more than just this plan is not going to be something we present to the public and say, hey, do you like this? This is a plan for us organizationally to move forward. But within that plan, it's prioritizing. We have to get community input into the work that we do. Does that make sense?
Yes. And just lastly, will there be any kind of general notification of you guys searching or looking for people to participate in this? And if so, when do you anticipate that coming out?
Yeah, absolutely. We will. That's actually one of the priorities is how do we communicate about these opportunities to get those voices in to the conversation. So yes, as far as timing, unfortunately, timing these days is challenging. But I do imagine that our plan itself is going to be done sometime in the first quarter of 2021, and then, as part of finalizing that, there will be timelines and steps that we'll be taking. So in another month or so, I'll probably be able to give you a better answer to that timing question, Tali. But I think in the immediacy, if folks want to get involved and have a voice at the table, we are looking for people that want to serve on our subcommittees. And we would love to see as diverse an application pool for that process as we could.
And we'll post a link to the health department's site in case folks would like to look for those opportunities on the subcommittees and who to reach out to. Just for the attendees, we do have many questions coming in. So we will be archiving all of these questions as well and seeing over the next month or so how we can address ones we're not able to get to today. But I'll ask a few more that have come in for you here, Frank. When the mental health department and the public health department merged, did their budgets stay and remain as high as they were when separate, or have the resources become less available to those departments?
No, the budgets are the same. And so they're actually still two budgets. So for 2021, there's a public health and a mental health budget. I think this point came up pretty frequently during the conversation about whether we should or shouldn't merge. And I think it was clear from the community, from both boards, that they wanted assurance that this wasn't a money-saving opportunity. And I can assure you that it's not. In fact, the county administrator, when he presented his recommendation, said that he believes that will likely end up costing the county more as we try to invest in more services and better ways to meet the needs of our community. So right now, it's all independent of COVID reductions that we had to deal with. The intent is that our budgets would be the same, and as we merge it together, we would be looking at achieving efficiencies so we could better use the money we currently have, and then talking about what new exciting things we want to do that might take additional resources.
Great. And we're getting a number of questions specifically about the mobile crisis team and its relationship with law enforcement. And these have come up in other forums with law enforcement officers as well. And this is something that all the working groups are talking about in addition. But has the mobile crisis team been a relief for the sheriff and IPD? Can you give us a little bit more into that relationship directly with law enforcement? And then the follow-up that's come up in a few different places is what might it take, or is it a sort of prudent idea to consider what mobile crisis might be able to do without law enforcement present, and what the position is on that work?
Sure. Yeah, so I'll start with the first one. I don't want to speak for our law enforcement agencies, but I do think we've seen many situations where the mobile crisis team has been able to intervene. And again, it's been my experience with our law enforcement agencies that they want mental health care provided to those that need it, rather than a law enforcement approach to it whenever possible. And so I think having us available has been beneficial. I will say that our program is small, right? As I described, it's people that are on call on top of the other work that they're doing to respond to these things. And so getting to the second question about not including law enforcement, really the mobile crisis team as it's designed now, because of the resources we have available to us, it's really for those individuals. When we're going on scene, it's really designed for those individuals that could be a potential harm to themselves or others. And in those settings, for the safety of our staff, at least at this point, that's the reason that we ask law enforcement to be there and partner with us, because you just don't know where those situations will escalate to. And our staff are amazing. They're amazing people, but I have to protect them as well. Do I think there are ways that we could expand the program where we might get involved in situations before it rises to that level? Absolutely. I think it's conversation that needs to be had. I think there's resources that would be necessary to do that. But we are willing and we are willing to be a part of those conversations and try to develop a program that meets the needs of our community.
Thanks. A question that came in through the Q&A. Does a mental health professional always evaluate an individual over the phone before 9:45? Is there always an evaluation included before that happens?
So in order to sign the 945, which is what orders the person to be transported, there are particular categories of people that are able to be reporters, they're called. And so the person signing the 945 has to have gotten information from someone that is a legally defined reporter in those situations for transport, and that can happen. So if the question is, does our social worker or our mobile crisis team person, do they talk to every single patient before they are 945? Not in every instance. We very much try to do those evaluations, but some are significant enough where the law gives particular reporters the ability to report to a 945 designee and then have a transport order issued.
Got it. And in terms of training, we're getting a few questions about cross-training between police officers or law enforcement officials and mental health officials, sort of coming from some of those same questions about law enforcement response. What does that cross-training look like between the two types of professionals?
Sure. So there's been several training opportunities where our mental health professionals and law enforcement have learned together over the last few years. I think it's an opportunity for growth for us as a community, where we could have more of that training occurring. Obviously, that's another question for law enforcement as well, right? How that fits into their structure. But I think we've had some opportunity to do that. I think there's definitely opportunity to do more in the future.
Thank you. Let's see here. We have a question about someone who works downtown and does some walkabouts in the downtown corridor and has noticed more and more used syringes in the community, in parking lots, open public spaces, and things to that matter. What are some of the plans around safe consumption or community safety around injection of drugs?
Yeah, it's certainly a difficult situation, because those folks are struggling with substance use disorders, and that potentially the leaving of needles behind creates a problem for the community in a broader sense. There's obviously been conversation about expanding services to folks with substance use disorders. There's more conversation that needs to be had. There are some organizations in the community that will come and pick up used needles if you report that to them. So there's the acute, how do we get the needle cleaned up? And then I think there are the broader conversations about added services for folks with substance use disorders to try to help them and try to get us to a point where we're not finding needles in our community.
There are some questions about the LEAD program, Law Enforcement Assisted Diversion, that the city recently received a grant for. Can you elaborate on what the health department and or your experience in the wider human services community has been with that program and what that may look like going forward?
Sure. Yeah, that's it's always exciting to see that amount of resource be brought into the community. So congratulations to the city and GIAC for making that happen for us. We've been at the table talking and trying to partner on LEAD since it was first mentioned a few years ago. I think one thing that I've always kind of looked to with LEAD is that we kind of do lead now. We don't put a lot of people in our jail. We do have a lot of human services available for our law enforcement community to refer people to. I think the one thing that LEAD brings that we might not have is kind of the coordination of that, right? And you know, the follow-up on the individual around all of the services that they can access. There's a couple of myths I want to dispel about kind of folks in our community that have issues. Sometimes I hear, you know, that they're not getting the services, or that nobody has provided them mental health or substance use treatment. If we could just get them into those treatments, it would take care of their needs. And it's way more complicated than that. It really is. Many folks that law enforcement is interacting with a regular basis, they're already connected to multiple organizations providing them help and supports. And their disease is just very challenging. And we can't require people to get treatment. You have to want to get treatment. And so it's a journey. And sometimes that journey has sidetracks that are not positive, and we have to work through those as we move forward. But I think LEAD it's a great thing. I'm excited to hopefully be a part of it as it starts to unfold, and look forward to any additional resources and support for the people we're trying to serve.
Thank you. We had another question about the mobile crisis team and the ways to engage them and get in touch with them. So you clarified earlier that ordinary folks can get in touch through the suicide or crisis hotline. Is there a plan, or is there a way for the mobile crisis team to have their own number? Why does it have to go through the suicide line? I think folks may be confused because they see that line as something you should only call if you are, if you have thoughts of suicide.
Sure. So I think this goes back to the way the program was designed with people that are on call, that have other work that they're doing. And so the thought being is that the trained professionals at the suicide prevention and crisis line can serve as that first triage point, right? And so if they're able to help the individual, again, get to a safety plan, then that's the least restrictive step, right? It's a phone call to our team, to the crisis line, and it begins the service provision at that point. And then from there, if they immediately recognize something is bigger than them, it goes straight to the mobile crisis team for activation. But again, understand these are folks that are on call, and they will take the calls and they'll figure out their next steps. But they ultimately have to, if they're going to the scene, they have to get to the scene from wherever they are. So it does create a delay. The challenge with having our own number is then somebody has to answer and run through those 24/7 in that coverage that the crisis line already provides. So instead of recreating something, we were really trying to use a pre-existing resource that is a great partner in our community to help build a program.
It certainly makes sense. Do you feel that the mobile crisis team is best in its current structure, or that it should be its own separate program? People may be confused about how it exists as sort of a secondary item for some staff members, or sort of a piece that's added on rather than its own response program.
Yeah. So the short answer is no. I think the ideal situation would be to have dedicated folks to crisis. And I think that's part of what our conversations need to be about as we move forward, particularly as we're talking about public safety reform. There is opportunity. It will cost money in order to provide the staff that could do that as a dedicated service. And it would change the program, right? Because we're doing it in this kind of on-call manner. We're really dealing with folks that are already in really acute crisis, right? That are in danger of harming themselves or others. The potential exists that the program could, as I said earlier, have intervention earlier in that process that could potentially prevent it escalating to that point. And I think that goes to all of the questions about would you need law enforcement and those things. If we had a different program, I think we could imagine something different for the community.
Great, thanks. I think I've been able to summarize most of the questions that we've gotten through chat and otherwise, but if folks on the Zoom would like to ask a live question, we have a few more minutes. Frank has another meeting to get to. But we'll take about 5 more minutes in case anyone wants to use the raised hand feature and answer or ask a question live. You could also type more out and I could ask, but want to offer the community that opportunity to ask live. So I'll just give it 20 seconds or so in case anyone wants to raise their hand. We did get a couple of ideas about more marketing on the mental health and suicide hotline so that folks know the crisis services available through that. So thank you to the participants who've shared those ideas. All right, we have a few that have come up. I'm gonna start with someone named Kai. Kai, you're up.
Hello, I just wanted to express something I felt listening to this. I listened to you fully and all your points, and I definitely agree that there's a lot of stuff going on, and I think that it's a lot more complex than people think. I personally have had a lot of experience with the crisis team, and I've had a lot of experience with family members going through mental health issues, and I would argue that most of my experiences have been pretty bad. So I would just like to point out that maybe the reason that isn't such a popular opinion that IPD is a good helper is something you should just consider a little deeper, maybe even just on the level that I'm listening to you. I would really appreciate that because there is a lot of truth behind what people have complaints about.
Sure. Yeah, absolutely, Kai. And I didn't by any means mean to minimize what folks are thinking and saying about law enforcement. We have work to do. We want to be a partner with everyone to try and find solutions so people like yourself and family members are having positive experiences when you're interacting with my department particularly. And so that is our goal, and hopefully you'll see as we move forward that we mean that, and we're trying to hear from folks about their experiences and how we can improve.
I appreciate that.
Great. Next we have Chris. Chris, you should be able to talk.
Yes, thank you very much. Good afternoon, Frank. And also, here's the question that comes up in the reimagining safety all the time is housing. And when you look back at the study that was done last year, 2019, for mental health, the intercept modeling one, out of the top recommendation was, again, housing. As though housing and the condition of housing is the source of mental health and policing issues. The responsibility for doing housing is not in either of those departments, police or the health department. Do you think, this is to you, Frank, do you think housing really is the source of these problems, mental health and criminality, we'll call it? Or is that simply something that the state of housing for people is simply a correlate? That is, they're running along together, but it's not a cause and effect. Did I make my question clear?
Yeah, I think so, Chris. And I don't know that I have all the data, in my head to be able to answer that very specifically. But what I would tell you is that we know that housing is a core social determinant of health, right? If you don't know where you're going to be laying your head that night, your ability to deal with any other issue in front of you is almost eliminated, right? Because you're trying to survive at that point. And what we would love to be able to see is that everyone know where they're laying their head tonight, so that way they don't have to worry about that and they can focus on the other issues that might be in front of them. And then we as a community have to figure out how to do that. You're right. I'm not responsible for housing in my official department head role. But if we truly believe that health equity is something we want for our community, housing first has to be a component of that. Because with that, again, if you don't know where you're laying your head, and then add on to that where your next meal is coming from, the rest of it doesn't matter. And so we could be talking about anything from their mental health or substance use issue or their diabetes or heart condition. If you don't know where you're sleeping, those things are not going to be a priority for you. So I don't know that I can specifically answer your question with data about correlation or causation, but if we don't look at housing and quite frankly the other social determinants of health as foundational in our efforts to try to improve things for those that need help from us, then we're going to struggle to be successful.
Thanks, Frank. And one more question before you have to go. I think it kind of wraps up some of what folks' sentiments are around mapping together mental health response and social determinants of health. If there was a scenario in which you had maybe unlimited funds or sort of long-term thinking, big goals, what interventions would you put in place on the prevention side for mental health crises? What are your visions on that?
Yeah, I mean, it'd be what we just said. If I had unlimited funds, I'd start by making sure everyone had a place to lay their head and a meal, that they didn't have to worry where those two things were coming from. Because when we talk about prevention and getting upstream, we can, we obviously need to address, the acute mental health or the acute health issues that individuals are facing. But so many of them are brought on by their environment, by their social structures, by our social structures that we've created, and their ability to have the basic human necessities, again, makes everything else most difficult. So, from that perspective, housing and, and food, access to care, all of those things are extremely important. If we're talking very acutely about the mobile crisis team, really, I think what we need to think about is what does our community want that to look like? And then once we understand what that is, then we have to figure out, what resources are available to make that a reality for us. So I think there's a lot of work, and I'll just say I also don't have all the answers, and I don't pretend to. I think we as a community have to come together and figure out what is going to be most important and have the most impact in helping people most in need.
Thanks, Frank, and thanks to all the community members who've showed up to ask questions and provide input today. We've archived and kept all the different chats and questions and comments. We've had more today than for a lot, and a lot of great ideas. So thank you everyone for those. We'll continue to offer more sessions along Reimagining Public Safety, including an upcoming one this Friday at 5 p.m. With officials from both the city and the county. But I want to thank you again, Frank, for your answers today and being able to provide all of the details on the mental health department and mobile crisis team. So I'm going to go ahead and end the stream on YouTube and just thank everyone again for tuning in today.